Welcome back to the deep dive. Today, we are taking a necessary and really focused look at one of the most pressing challenges in global health.
The cancer epidemic.
It's a cancer epidemic. Our source material today is from Approaching Global Oncology, a text that just zeroes in on the science and systems we need to overhaul how the world fights this disease. This deep dive is really designed to be your shortcut to understanding the future of global cancer care.
And when we talk about the scale of this, the statistics are just. They're impossible to ignore. Cancer is the second leading cause of death worldwide. But for those of you studying global health, you have to internalize this disparity.
It's huge.
A staggering 70% of the nearly 10 million annual cancer deaths happen in low and middle income countries. LMICs. We're talking about vast regions of Africa, Asia, Latin America. And if that wasn't enough, it's projected to rise to almost 30 million new cases a year by 2040.
That is a massive gap, and it often leaves people feeling, overwhelmed, like the problem is just too big. But the sources, they don't just dwell on the tragedy. They champion a proactive strategy, something called the win-win movement. What's the core idea there, beyond just standard humanitarian aid?
The win-win movement argues that we really shouldn't approach this as pure charity or, a one-way street of resources. Instead, it advocates for a global scientific and systemic shift. The whole aim is increasing the affordability of better value cancer care.
Better value?
Yes. And the win-win part is that if care becomes more affordable and effective in these resource-limited settings, the solutions, be they scientific, technological, or financial, will ultimately benefit everyone: patients, health systems, the pharma industry, even wealthier nations that are facing their own rising healthcare costs.
So it reframes the crisis as an opportunity for innovation that helps everybody. Okay, so for you, the learner, the medical student, the young professional tuning in, we have a very clear mission today. We're breaking this down into two critical parts. First, the scientific and clinical tactics we need to increase value and affordability.
Yep.
And second, the systemic approaches and collaborations that are required for global implementation. Let's start with the science, because that's really where the whole philosophical shift begins.
Right. Traditionally in healthcare, we focused on, effectiveness, efficiency, but the sources highlight a new dominant metric. They call it the metric of the third industrial revolution in medicine.
Value.
Value. So how do we measure that?
Value just fundamentally changes the scorecard.
Okay.
It's defined as patient-centered outcomes achieved
Okay.
versus the total cost. And that is the crucial distinction. We're moving away from paying for volume, how many tests were run, how many milligrams delivered.
To evaluating the total outcome relative to the resources we spend. This immediately shifts the focus onto sustainability and accessibility, and those are non-negotiable in global oncology.
And this shift in mindset, it immediately goes after a really long-held dogma in oncology, the idea of the maximal tolerated dose, or MTD. This is where it gets interesting, because historically the belief was always more is better, a higher dose is better.
That notion it's really deeply rooted in the history of chemotherapy, where toxicity was sometimes, equated with efficacy. But for modern, highly targeted drugs, I'm talking about kinase inhibitors, monoclonal antibodies, that thinking is often just obsolete. Outside of oncology, standard pharmacology says you seek the optimal dose.
The optimal dose.
The lowest effective dose that gives you the maximum clinical effect. Continuing to dose patients to the point of unnecessary toxicity is not just harmful, it's financially illogical, especially if the biological target is already saturated at a lower, less toxic dose.
So the scientific work now is focused on proving we can reduce that dosing without compromising the outcome. That's how we get better value. And we have some very specific clinical examples of this. Take trastuzumab, a foundational drug for HER2-positive early breast cancers. Shorter courses of treatment are now being seriously explored as a viable option. That reduces therapy length and, of course, the cost.
A fantastic illustration of this is the drug ibrutinib. It's used for chronic lymphocytic leukemia, CLL. The standard dose is 420 milligrams a day. But advanced pharmacokinetic and pharmacodynamic data, PK/PD data, which is how the body affects the drug and vice versa, it suggests we could potentially reduce that dose dramatically.
How dramatic?
Maybe even down to 140 milligrams daily without compromising the drug's biological activity at all. The data just suggests we hit maximum therapeutic benefit way before we reach that old maximal tolerated dose.
And we're seeing this extend into cutting-edge immunotherapies too. Consider nivolumab. Instead of a higher dose every 2 weeks, there's a movement toward a reduced frequency shifting to 480 milligrams every 4 weeks.
which is huge, not just for cost, but think about patient convenience. It drastically cuts down on required clinic visits.
Absolutely.
And for monoclonal antibodies like atezolizumab, personalized dosing is being explored using something called therapeutic drug monitoring, or TDM. The goal there is to individualize the dose to maintain a very specific therapeutic trough concentration. We call it the Kleeman,
With speed.
right, of at least 6 micrograms per milliliter. The Kleeman is basically the lowest effective drug level you need in the blood to keep the therapeutic effect going. By measuring and maintaining that minimum level, we can sometimes space out the dosing or reduce the total amount. Same outcome, fewer resources.
What's really remarkable is that sometimes the strategy isn't about complex TDM. It's about something really simple and practical.
Right.
The sources cite examples where simple food effects can dramatically reduce the required dose and, critically, the cost.
Exactly. For lapatinib, a 1,250 milligram dose on an empty stomach can be cut to 500 milligrams taken with food. Similarly, abiraterone. It needs 1,000 milligrams when fasting. That can be dropped to just 250 milligrams taken with food.
Wow.
These seemingly small, value-based prescribing strategies, just leveraging simple eating habits to increase bioavailability, they could collectively save over $12 billion globally per year.
That is the definition of value.
It is.
So beyond just dose reduction, another vital scientific tactic is drug repurposing. This means taking an existing FDA-approved drug, maybe an old, safe, non-cancer drug for, say, diabetes or arthritis, and testing it for a new use in oncology.
This is a tremendous lever for affordability. Repurposing completely eliminates the need for new drug development. It bypasses the decades-long, multi-billion-dollar costs of novel compounds. It's also being used to create new, effective combinations of older cancer drugs.
Right.
And organizations like Cures Within Reach are actively funding this specific area. They even created programs like repurposing grants for the rest of the world to specifically target researchers in LMICs.
So they can test these existing drugs in new oncology contexts.
Exactly.
That bridges us perfectly from the science to the systemic barriers. Because even when we find these amazing low-cost solutions, implementing them globally hits an immediate wall.
The risk of counterfeit medicine.
Yes.
This is a really underestimated defect in the system. Counterfeit medicine is a mammoth, $200 billion criminal market. It's estimated to cause 1 million deaths annually, worldwide.
Yeah.
It completely undermines quality.
And the clinical danger is immense. This isn't just fake aspirin. 60% of these fake products are for life-threatening conditions, including cancer.
And the high price of legitimate, patent-protected medicine is what drives the demand for these counterfeits, especially in developing countries where patients are desperate. Any effort toward quality, affordable healthcare is just nullified if the drug supply chain is polluted. We have to secure that pipeline.
And that's where technology steps in.
It has to.
So what does this all mean for tech? The sources are really clear that information and communications technology, ICT, and artificial intelligence, AI, are absolutely essential. And the key phrase here is augmenting human intelligence, not replacing it.
Precisely. AI and ICT are critical because of the severe shortage of oncology professionals globally. AI tools can support early detection, for instance, improving speed and accuracy in digital pathology, or helping to analyze new, less invasive tests using, say, saliva instead of blood. They also radically improve treatment planning.
And when you look at the workforce, the shortage is only getting worse. We know that by 2025, the U.S. is projected to face a shortage of nearly 1,500 oncologists.
And if that's the reality in a high-income country,
Imagine the situation in Africa.
it emphasizes the prediction made by the authors. They say, those who use AI will probably replace those who do not. The oncologists of the future won't be replaced by machine. But their role changes. AI handles the massive data sets, it automates scheduling, flags standard cases.
Frees up the human.
It frees the highly trained human expert to focus on the most complex problems and the nuanced, patient-centered decisions.
We've actually seen proof that systems can adapt quickly when they have to. The COVID-19 pandemic, while a tragedy, it acted as this massive catalyst for innovation, especially the rapid adoption of telemedicine.
Oh, the change was immediate and undeniable. The percentage of physicians using telehealth in the U.S. shot up from under 20% to almost 50% in early 2020. This shift, it reduces the cost of delivery, it slashes travel time for patients in remote areas, and it just dramatically increases convenience. This flexibility, driven by crisis, is a model we have to sustain.
But while telemedicine lowers the cost of delivery, the cost of the actual drugs is still a massive barrier, which is where this concept of financial toxicity comes in. How do systems manage the fiscal distress patients face?
It requires a systems-based solution. The Levine Cancer Institute in the U.S. pioneered something called the Financial Toxicity Tumor Board, or FTTB. It's modeled after a conventional tumor board, but it focuses exclusively on fiscal distress.
So who's on it?
It gathers physicians, financial counselors, social workers, pharmacists,
Hmm.
all to proactively review treatment plans and cost scenarios for patients who are at risk.
It's a truly multidisciplinary approach,
Right.
focusing on the total cost of care. What was the impact?
Through the STTB and other assistance programs, the Institute helped avoid approximately $60 million of personal expenditure for nearly 1,800 patients.
60 million.
It just proves that managing financial toxicity has to be an explicit part of comprehensive cancer care.
Let's move to our third part, global collaboration and infrastructure building. Because these solutions, they have to be shared, the sources strongly advocate for reverse innovation. This isn't a one-way street of high-income countries helping low-income ones.
That's right. Reverse innovation is this pivotal idea that affluent countries can and should learn from the low-cost, high-value solutions that were developed out of necessity in resource-limited settings. For example, a cost-effective cancer technology that works reliably in a remote African clinic could be perfectly suited for an underserved rural population in the United States. It saves costs and increases access for both.
And if we connect this to infrastructure, the gap in access to essential technologies is enormous. For example, only 5 to 7% of cancer patients in Africa have access to radiotherapy.
Despite it being necessary for over half of all cancer patients globally, that's a crisis, and it requires both scientific innovation and financial ingenuity. On the science side, we have things like hypofractionated radiotherapy, or HFRT.
What's that?
It delivers larger doses over a shorter time. Crucially, in LMICs, this dramatically reduces the number of patient visits. It cuts down on travel costs, time away from work, the whole thing.
And scientists are looking even further ahead with tools like smart radiotherapy biomaterials, SRBs.
Yes, these are low-cost, next-gen fiducial markers, tiny implants that guide the radiation beam. When you combine them with HFRT, you could potentially get to single-fraction radiotherapy. And preliminary studies suggest this combination boosts both local and metastatic tumor kill.
A low-cost, evidence-based approach to making a high-tech treatment accessible.
But technology still costs money, which brings us to innovative financing. Instead of expecting nations to bear the enormous upfront capital costs of buying things like linear accelerators.
They find new models.
Exactly. The National Cancer Institute of Uruguay offers a perfect real-world example. Instead of buying 2 linear accelerators, they chose to lease them.
And what were the benefits of leasing?
Immediate and manifold. They instantly got state-of-the-art tech without the huge initial outlay. Crucially, the lease included service and spare parts. It transferred the maintenance risk to the provider, and the contract guaranteed machine downtime wouldn't exceed 2%, far better than the industry norm.
It's a powerful blueprint. But infrastructure also means human capacity, maybe the most critical bottleneck.
This is where digital platforms are changing the narrative from brain drain to global health gain.
Brain drain being when professionals leave LMICs for training abroad.
Right, and 2 platforms are driving this change.
Mm.
The Global Oncology University, or GOU, and the Comprehensive Cancer Center in the cloud, C4.
GOU is education.
Yes, world-class online education. But it's complemented by...
Okay, so we've really distilled the approach. Increasing affordability and access in global oncology requires really sophisticated thinking, scientific rigor, innovative tech like AI, and new financial models like leasing and reverse innovation.
I think the most important takeaway is balance. The complexity here absolutely requires tools like AI to handle the data, but human judgment remains critical.
How so?
Especially when weighing things like patient toxicity, the distance they have to travel, the socioeconomic impact. That ability to synthesize data with human factors is an art. It's learned over years of training.
We have to keep monitoring those AI models, right? Guard against the pitfalls of the digital subconscious.
Absolutely. The bias and blind spots that can creep in, the human element of clinical wisdom is and will remain irreplaceable.
As you move forward in your studies or practice, let's leave you with this review exercise to really cement the concepts we discussed. We detailed the shift from maximal tolerated dose to optimal dose. So for a young professional looking to maximize value-based prescribing, describe two specific scientific strategies, and let's say beyond simple dose reduction, that can achieve the same therapeutic effect at a lower cost or reduced frequency.
And try to cite examples from kinase inhibitors or monoclonal
We
antibodies.
think about the pharmacokinetics and how external factors or new monitoring techniques can influence both efficacy and accessibility.
It's a great thought exercise.
A huge thank you for joining us on this deep dive into global oncology. Now go apply those principles of value and collaborative science in your own field. That next great win-win idea is out there, waiting for you to find it.